Well, good evening, everyone. I want to welcome you to this Contemporary Pediatrics webinar that's entitled Multisystem Inflammatory Syndrome in Children, or MISC, a new wrinkle in COVID-19 infection. My name is Dr. Tina Tan. I'm Editor-in-Chief of Contemporary Pediatrics and a Professor of Pediatrics at the Feinberg School of Medicine of Northwestern University and a Pediatric Infectious Diseases attending at Ann and Robert H. Lurie Children's Hospital of Chicago. I am joined tonight by two very distinguished experts that are going to be speaking on this topic. The first is Dr. Stanford Shulman, who is the Virginia H. Rogers Professor of Infectious Diseases and a Professor of Pediatrics at Feinberg School of Medicine at Northwestern University. He's also an infectious diseases attending at Ann and Robert H. Lurie Children's Hospital of Chicago. And the second presenter is Dr. Leonard Krylov. He is Chief of Pediatric Infectious Diseases and Chairman of the Department of Pediatrics at New York University, Winthrop University Hospital, and Professor of Pediatrics at the State University of New York, Stony Brook School of Medicine in Stony Brook, New York. So what we're going to do tonight is basically talk about the multisystem inflammatory syndrome in children, which recently appeared here in the United States and elsewhere in the world. And by way of background, what I'm going to do is sort of set the stage and talk a little bit about what's been going on with COVID, and then turn the podium over to our distinguished speakers. So we know that in mid-December of 2019, COVID-19 was identified as the cause of an outbreak of respiratory illness in Wuhan, China. And since that time, COVID-19 has been officially declared a global pandemic and has rapidly spread worldwide. As of this past Tuesday, globally, there have been over 4.7 million cases of the disease and over 315,000 deaths. And here in the United States, there have been over 1.5 million cases and almost 90,000 deaths that have occurred. We know that persons of any age can be infected with COVID-19, with infants and children generally presenting with mild symptoms. However, studies have shown that infants under 1 year of age and children with underlying conditions are at greater risk for developing severe COVID-19 disease if they get the infection. Now, in late April, multisystem inflammatory syndrome in children, or MISC, potentially associated with COVID-19 infection, was first described in the United Kingdom. And since that time, cases have been reported in Spain, Italy, France, and here in the United States. And to date, there have been over 100 children in New York State that had been diagnosed with MISC, with 3 confirmed deaths. And there are now multiple cases being reported from other states all across the U.S. These serious cases mimic the symptoms of Kawasaki disease and or toxic shock syndrome, with a disease course that seems to suddenly worsen days after children seem to have initially recovered from a possible coronavirus infection. So given that this particular syndrome is spreading all across the United States, it is very common or very likely that you will see one of these children, or possibly one of these children. So the objectives of this particular webinar are basically to inform clinicians as to what MISC is and how it can mimic some of the findings in Kawasaki disease and or toxic shock syndrome. Basically help you recognize and treat MISC, and talk about how MISC may be potentially related to COVID-19 disease. And with that, I'm going to turn the webinar over to Dr. Krylov.
Thank you, Dr. Tan, and good evening, everybody. So as Dr. Tan just demonstrated, the newness of this syndrome, something that 4-6 weeks max of experience, we do need to understand that it's still evolving. And as in any syndrome, the definition may not be complete, certainly isn't here yet, And one of the caveats is always exclusion of any other known cause of the patient's signs or symptoms. So with that said, I wanted to show you two different definitions that have been literally over the last week published, because I think they'll show you where we are or maybe even aren't in our understanding of this syndrome. So this slide, called Multisystem Inflammatory Syndrome in Children, or MISC, provides the CDC working definition as of May 14th, so literally less than a week ago. It includes age under 21 years of age, presenting with fever, and again, classic definition of fever, just 38 degrees centigrade, although in our experience, most of these children have had very high fevers, or even potentially subjective fever if fever hasn't been documented. And then as evidence, it's a multisystem disorder having large, greater than 2 organ involvements. So cardiac involvement, we'll describe in a minute, renal disease, respiratory disease, GI disease, dermatologic changes, again suggesting the similarities or maybe similarities or overlap to Kawasaki disease, and even potentially neurological manifestation. And then the other thing, as Dr. Tan mentioned already, there has been an association temporarily, although delayed from the onset and the peaks of COVID disease. But in addition, many of these patients have had evidence by either nasal swab, PCR, or antigen test, serologic evidence, or at least some exposure to known confirmed COVID cases. So it's somewhat general, but it does start to paint the picture. The next slide begins a series of a couple of slides on the definition, temporally associated with COVID. New York State calls it pediatric multisystem inflammatory syndrome in children. But the same concept, but adds a few differences that I do think are helpful in starting to think about this. Besides the age being the same and the fever, it does break it into sort of 2 different presentations. And I think as we're looking at this more and starting to see more, it really is potentially 2 different presentations. And these are children who've ranged from 3 to 4 years of age. Some have even described younger children up through adolescence. But the older children, so to speak, the 10, 12 adolescent age range, tend to present more with multisystem disease. They may present in shock with evidence of myocarditis, significant GI symptoms. And although they may have some of the rash manifestations, they tend to be less severe or less prominent potentially than in the younger children. But both can be involved in both age ranges, and so the CDC is a little more general. Here in the New York State definition includes potentially the organ system involvement, and then lists separately 2 or more of the rash characteristics, and also in that category, which as we'll come to, even though there are some Kawasaki-like features of the rashes, differences, and one of the main ones, even in the younger children, has been more prominent gastrointestinal symptoms, abdominal pain, diarrhea, than typically seen in classical Kawasaki disease. And I know Dr. Shulman will give us more explanation or description of that as well. Next slide. Again, just emphasizing from these criteria the evidence. Whoops, back one if we could. Emphasizes just the summary of those top common symptoms: irritability, some degree of lethargy, abnormal pain, especially abdominal, but without other explanation. A number of these children have been worked up suspicious for appendicitis before the other features were recognized. Diarrhea, vomiting. They may have some similar non-purulent conjunctivitis seen in Kawasaki disease, but again, other features as well. Similarly, they may have a single enlarged lymph node similar to that described in Kawasaki disease, and mucous membrane involvement with the strawberry tongue, red lips, and even swollen hands and feet. Next slide, if you would. And as we look, the next part of the New York State criteria spells out again a little bit more of the laboratory and epidemiologic criteria that I mentioned, and it's there in the CDC definition, but this spells it out, I think, in a little bit more detail. So again, the laboratory data, there's no specific test. The general criteria are various measures of inflammation, but I think as we look at it more and more, for these children with MIS-C, that there is more of what our house staff are calling the COVID labs, the increased D-dimer fibrins extraordinary levels, the increased ferritins, unique and different from Kawasaki's, often thrombocytopenia at onset, not the normal that goes on to thrombocytosis that's described in Kawasaki disease. Lymphopenia, again, a striking part of adult COVID disease, may be seen as here as well. And then other inflammatory markers that may be a little bit less specific. And then the virologic criteria, again, may include a nasal swab PCR or antigen test, if that's what used, that identify evidence of at least part of the virus, not necessarily viable virus, and or serology demonstrating antibodies against SARS-CoV-2, the presumed etiologic agent of COVID-19. Additionally, they describe in a little bit more detail the epidemiologic links that have been seen in many of these patients. And usually it is not simultaneously. It's adults, parents, or others in the household several weeks to even a month before. They liberally include up to 6 weeks before an exposure to a known or presumed likely COVID case, and add that as part of the definition or criteria to screen in looking at this. And then they give you a, quote, confirmed diagnosis, that is the clinical criteria, the laboratory criteria, and virologic criteria, or presumed if they have the general lab criteria, the clinical findings, but not confirmation of COVID infection or exposure. So those are the working definitions that we have been developing so far. I think, as I say, even within this, it's probably different by age, and there's going to be a little bit more fine-tuning as we go forward. The next slide just demonstrates from 2 of our cases in younger children what some of the rash findings have been. So yes, strawberry tongue, red swollen hands in this case, and the child below, who again having the non-injected conjunctivitis that's described in Kawasaki, but also, and this has been described now in several more cases, more of a heliotropic or surrounding erythema around the eyes, as well as the injected conjunctiva that are seen in Kawasaki disease. So that's my overview of what the definition is and some of the clinical findings at this point. And we'll have Dr. Tan turn it over to Dr. Schulman.
So Dr. Schulman is going to present the next several slides looking at the comparison between MIS-C and Kawasaki disease and toxic shock.
Thank you. Thank you, Dr. Tan and Dr. Kriloff, and good evening, everyone. So this slide goes at the left side some of the classic features of Kawasaki disease that most physicians taking care of children recognize. So we have the rash, we have the injected eerie-looking eye, since it's a single eye we're looking at here. The injected conjunctiva, non-inflammatory, more injected, that blood vessel, dilated vessels, strawberry tongue, the red palms and soles, as you can hear, cervical adenitis, which is curiously virtually always unilateral. We have here evidence of vascular aneurysms, peripheral aneurysms, which are very rare in Kawasaki disease, and virtually always occur together with abnormalities of the heart, which are the most important features of Kawasaki disease, as I'm sure you all know. So coronary artery aneurysms may develop in Kawasaki disease, particularly when it's untreated in time, which is usually considered by the 10th illness day. But even with timely treatment, aneurysms occasionally develop, and those aneurysms may lead to thrombosis, coronary thrombosis, and myocardial infarction. Alternatively, quite a rare complication, and usually in very young children, coronary artery aneurysm may rupture. And that occurs, when it occurs, is typically within the early months after the onset of the disease. And then a more common phenomenon in children who develop coronary aneurysms with Kawasaki disease, over time, they may develop coronary artery stenosis, typically at the entrance point or exit point of an aneurysm. And there may be progressive obliteration of the lumen due to proliferating modified smooth muscle cells. And if you look at the bottom right of this slide, you can actually see from the only fatality we've had at our hospital in Kawasaki disease in over 2,500 cases is this child who shows two coronary vessels, one with a huge thrombus, the other with massive proliferation of the smooth muscle cells to the point of totally obliterating the lumen of the vessel. Shown at the top right is a heart with giant coronary aneurysms that essentially are the size of the pulmonary artery or aorta. And then shown in the middle bottom is a coronary angiogram. These vessels should be narrow and relatively straight, and you see massive giant coronary aneurysms and irregularity, and even maybe an area of stenosis over here on the, I'm not sure my cursor is showing up, but to the right part of this picture of the angiogram. Next slide, please. So I'd like to compare what's been being described really in just a few seminal articles so far published just in the last 3 or 4 weeks of COVID-19 shock and collections of patients versus what in the Kawasaki field we talk about Kawasaki disease shock, or we like to call it Kawasaki patients. And these patients make up about 1 or 2% of all Kawasaki disease patients. Typically, Kawasaki disease does not lead to shock, except in this 1 or 2% of patients who manifest fever and shock-like syndrome. Often they lack the typical Kawasaki disease features that we've already talked about. But then as they are in the intensive care unit being treated for toxic shock and Kawasaki shock, they often start popping up with red eyes or red lips or other features of Kawasaki disease. So there are some striking differences between Kawasaki shock syndrome patients and the COVID-19 shock patients. Very typical of COVID-19 infection is lymphopenia. That's true in the few cases that are, that is true in the adult cases who present with COVID-19. It's also true with, in the pediatric cases. Lymphopenia is quite a common circumstance, and in these series of cases that have been reported now, lymphopenia has been not universal, but quite prominent. And that is something that is not recognized. We don't see that in Kawasaki shock or toxic shock type patients. The demographics are worth talking about for a moment, more than a moment. In Kawasaki shock and in Kawasaki disease without shock, Asians people of Asian ethnicity are by far at the highest risk of developing these conditions. And in Japan, which has the highest attack rate of Kawasaki disease in the world, the attack rates are at least 10 times higher than that we see in North America or Europe, and particularly in Caucasian patients or Black patients. And what's been recognized with the recognition of COVID-19 shock patient or MIS-C syndrome is that there are no reports from Asia of Japanese, Chinese, or Korean children who all have marked susceptibility to Kawasaki disease. None of those patients in those countries have been reported to develop this new syndrome, despite the fact that there's been an awful lot of SARS-2 infection, of course, in Asia. In addition to this, and the other thing I should point out, and this is a soft finding, but there are hints within some of the published series of cases of COVID-19 shock that sound like perhaps an overrepresentation of African American or African Caribbean or African European patients. So the series of 8 cases from the first report from the UK, 6 of the 8 patients that they described in this first report were Afro-Caribbean background. And we do know that there's been a disparity with COVID infections in general in our country with overrepresentation of African Americans, which may have to some degree of genetic basis, although there are certainly other very likely predispositions, such as comorbidity. So from the racial and the age relatedness, there's clear differences between, I actually didn't talk about this yet. So the age differences, in Kawasaki disease, the median age is 2 years. 50% of children are under the age of 2. 80% of the children are under the age of 5. Clearly, Kawasaki disease, with or without shock, is skewed towards the very young children, the preschool age children, even though we know that there are occasional cases that are older, even a handful of adult cases. But the predisposition of very young children is dramatic. In COVID-19 shock patients, or the MIS-C syndrome, the vast majority of patients are over the age of 5. I will be talking a little bit about a series that was just published today from France of 35 children with MIS-C, and only one of those children was 5, and none of them was under the age of 5. In contrast, the median age was 11 years, and there were a number of teenagers and adolescents. So the age distribution, the apparent racial distribution are very different between these two illnesses. It's already been mentioned that the MIS-C patients, one of the most common early presentations, other than fever, is severe abdominal pain. And while Kawasaki children occasionally manifest some abdominal pain, often related to hydropic gallbladder, the abdominal complaints do not dominate the clinical picture in Kawasaki disease very often at all. Whereas in the MIS-C patients, severe abdominal pain accompanied most often by diarrhea, sometimes by vomiting, or vomiting and diarrhea, has really become a hallmark of this particular infection. Some of the laboratory tests that we see in the MIS-C patients, we see elevated ferritin levels, we see very elevated CRP levels. The average CRP level in Kawasaki disease is around 8 8 or 9 milligrams per deciliter. These patients with the COVID-19 shock syndrome have CRP values double or triple or even quadruple those particular levels. I've seen reports of CRP levels up to over 40 milligrams per deciliter. And the platelet counts and albumin levels in the patients with MIS-C are lower than normal. Thrombocytopenia has been mentioned and should be mentioned again. Hyperalbuminemia is extremely common. And what we see in Kawasaki disease are patients who start out with a normal platelet count and then develop a dramatic thrombocytosis, often between 1 and 2 million platelets during the around day 14 to 21 after the onset of their illness. And hypoalbuminemia is also a common feature in Kawasaki disease, but it is less dramatic than has been reported in the COVID-19 group of patients. So here we have the platelet counts normalized in COVID-19 shock, but the marked thrombocytosis I already mentioned. So one of the clearly probably the most important aspect of the COVID-19 shock MIS-C syndrome is severe myocardial dysfunction. And whether it's true myocarditis with infiltration of cells in the myocardium is yet to be proven, but the myocardial dysfunction in these patients is quite dramatic. And that's manifested by very elevated NT-proBNP levels, approaching 50,000, when the normal range is well under several hundred. And troponin levels are also moderately to markedly elevated in these MIS-C patients. In Kawasaki disease, these values are not particularly elevated, but in the Kawasaki shock subset of Kawasaki disease, these lab tests are generally pretty mildly elevated. There is myocardial dysfunction for sure in the Kawasaki shock patients, but it doesn't appear to be as dramatic as in the COVID-19 shock patients. And overall, Kawasaki disease patients in general have a risk of about 25% of developing coronary artery aneurysms if they're untreated, and about 2 to 5% if they are treated with intravenous immunoglobulin. But those numbers are higher, as high as 60% of the Kawasaki disease subset of patients who have this Kawasaki shock type scenario. So I wanted to share with you some information hot off the press. Really, I just published today the French series of MIS-C, the multi-system inflammatory syndrome of children, from 12 hospitals in France and 1 in Switzerland. They have 35 patients diagnosed between March 22nd and April 30th. That's a 5-week period. The criteria that the French used, much more simple than what Dr. Priloff has presented from the CDC and from the New York State Department of Health. The criteria the French folks used was just fever, cardiogenic shock, or depressed left ventricular ejection fraction below 50%, and elevated CRP level. The median age, 10 to 11 years, and I think I mentioned already that one of those 35 patients under the age was 5 and under. 19 of the 35 patients were 11 to 16 years of age. A very dramatic difference in age from Kawasaki disease. SARS-2 infection in this series of 35 patients was confirmed in 31 of the 35, that's 90%. and about a third of them were PCR positive for the SARS-2 virus, and 30 of the 35 patients were positive for antibody in the serum to SARS-2. That fact alone, with a very high rate of antibody positivity, to me suggests, along with some epidemiologic evidence, that this COVID-19 shock syndrome is behaving like an illness that is occurring 4 to 6 weeks after the peak of COVID infection in a community. And there seems to be a latency between the original exposure/infection of these patients with SARS-2 and the onset of this new syndrome. I make an analogy. Don't mistake what I'm about to say, but we've long known that strep throat is a trigger for acute rheumatic fever, which occurs 3 to 4 weeks after the strep throat that was untreated, and that during that period of time, the strep disappears, the immune system is doing its thing, that takes weeks, that results in rheumatic fever. I think in a similar fashion, what we're learning about this new syndrome related to SARS and COVID-19 is that very often there's a history of an exposure to someone in the household, typically, with COVID-19, in the adults, or an adult, and then 4 to 6 weeks later, 3 to 6 weeks later, at some interval later, a child in that household, typically an older child, who did not experience symptoms in the early phase when the adults in the family did, now develop this new syndrome. So I think there's an analogy, and I think we can refer to this as a post-infectious phenomenon rather than an infectious phenomenon. Infection aspect is the viral infection, usually causing pneumonia, which most children escape. But then this appears to be a post-infection problem. So the clinical features in the French patients, they all had fever and what the French called asthenia, A-S-T-H-E-N-I-A, which just means they feel terrible. They had 80% of these patients had abdominal pain with vomiting or diarrhea, and 2 of them actually underwent appendectomy, where a normal appendix was found, with mesenteric adenitis was seemingly at least part of the explanation for the abdominal pain. The French patients, each individual patient had 1 or 2 or 3 Kawasaki resembling features, but none of these patients met the full criteria for Kawasaki disease. 29 of the 35 French patients were directly admitted to the intensive care unit with a diagnosis of cardiogenic shock. 10 of the 35 patients received mechanical circulatory assistance via a venous arterial ECMO, which they received for 3 to 6 days. In addition, 2/3 of these patients required mechanical ventilation. So obviously, an extremely ill subset of patients. The median CRP level was 24, ranging up to 31 in this group of patients, and IL-6, which some data suggest is highly related to the hyperinflammatory state of this syndrome in children and the hyperinflammatory state that occurs in some adults with classic COVID infection. The IL-6 levels were elevated in 13 out of 13 of these French patients. The echocardiograms are interesting in that 10 of the 35 French patients had left ventricular ejection fractions under 30%, which is moderate to severe dysfunction, and 30 to 50% ejection fractions were observed in the other 25% patients with mild to moderate depression of ejection fraction. 31 out of the 35 patients by cardiac studies could be shown to have hypokinesis of the left ventricle, indicating the cardiogenic nature of the shock that these patients have manifested. Kawasaki disease, the hallmark, of course, in the heart is coronary artery aneurysms. In the French series of patients, 6 of the 35 patients were reported to have coronary artery measurements with a Z-score of greater than 2, but they don't tell us how much greater than 2. Z-scores of 2 to 2.5 or even close to 3 are not particularly surprising in non-Kawasaki children who are extremely ill. Of these 6 children in the French series with measurements greater than the Z-score of 2, 5 of the 6, the vessel involved was the left main coronary artery, and 1 was the right coronary artery. And the latest guidelines for Kawasaki disease suggest that we probably should not be focusing on the left main coronary artery because it's so short and it branches immediately. It's very difficult to measure precisely in many patients what the dimension is of the left main coronary artery. So there's been a trend to sort of not focus on that particular vessel dimension. In any case, none of the French patients developed aneurysms. All of them survived, and the therapies that they received, they almost all received inotropes. 25 of them received IVIG. 1 patient received 2 doses of IVIG. 12 patients received intravenous steroids, just like commonly used with IVIG in high-risk Kawasaki children. And most patients have responded quite dramatically, as sick as they are, when they come in through the door, really within 48 hours of typically IVIG with or without steroids, almost all the patients are dramatically improved. 3 of these patients in France received anakinra. The outcomes, 28 of the 35 French patients have gone home. 28 of them, 25 have gone home with a normal left ventricular ejection fraction. That's pretty dramatic. 7 of them, at the time of this report was written, were still in hospital or had very mild residual left ventricular dysfunction, but all had ejection fractions greater than 45%, and all survived. So there's one other condition that needs to be mentioned. If I could have the next slide. We should talk a little bit about toxic shock syndrome in addition to Kawasaki syndrome and the MIS-C syndrome that we just talked about, related almost certainly to infection with the SARS virus 2. So staphylococcal and streptococcal toxic shock have been known for a long time. Intensive care physicians are always on their toes when patients are admitted to the intensive care, children and adults with shock. And these patients have a variety of organ system involvement. And in fact, the PVC criteria to diagnose staph toxic shock and group-based strep toxic shock require evidence of organ system dysfunction. Rare patients of these syndromes have positive blood cultures, but some of them do, and most of them have a definable site of colonization with staphylococcus or a focal staphylococcal infection. We've seen it with empyemas, pneumonias, bone and joint infections. And you can see that both of these syndromes are called toxic shock syndrome because the illness is really mediated by toxins produced by Staph aureus on the one hand, or Groupe strep on the other hand, and it's really these bacterial toxins that mediate the multi-organ system damage. The mortality rate in staph toxic shock is around 10%. So it's obviously a serious condition. This is in older adolescent girls or in young adults. Staph toxic shock syndrome can be tampon associated. In fact, the first pediatric series of staph toxic shock from Denver by Dr. Jim Todd, nasal tampons were associated with several of the cases of patients who had epistaxis, had a tampon in the nose to curb the bleeding, and it was identified that Staph aureus was present. Toxin-producing Staph aureus was found in that nasal site in those kinds of patients. So I don't want to take up too much time here, but we've been moving along. I want to say that IVIG is considered standard therapy for Kawasaki disease. It's pretty much standard therapy for toxic shock disease because IVIG contains antibodies to a number of the staphylococcal toxins, and probably benefits the patients. And it seems like IVIG should remain the hallmark, the starting point for treating patients with MISC when they first arrive, and many patients respond to IVIG alone. Some will receive IVIG and steroids, and IV antibiotics, of course, are important to cover the gram-positive strep and staph organisms until you can rule out toxic shock syndrome. Other agents have been used in Kawasaki disease for refractory Kawasaki disease patients, such as infliximab. And with respect to some of the other adjunctive therapies for the MISC syndrome, there's a couple patients that have been treated with anakinra in addition to the 3 in the French series. Tocilizumab in one patient in New York State that I'm aware of. Anakinra, I've already mentioned. So I think this is the end of my overview of these topics, and I think we should open things up to question and answer.
Excellent. So the first question will go to Dr. Krylov, and the question is, do these kids present very ill suddenly, or do the symptoms worsen over time?
It seems to be a fairly sudden presentation, and I think that's why the CDC and New York State criteria mention 1 or 2 days of fever, not the 4 or 5 days or more of fever that are used in the diagnosis of Kawasaki disease. So they seem to come in sudden onset and sick very quickly.
The next question is for Dr. Schulman. The question is, are adults considering or using IVIG in cases of COVID-19 induced cytokine storm?
Yeah, so that's a great question. So adult COVID infection appears to have, in many patients, 2 phases. There's the early phase when they present with pneumonia particularly, and are very commonly have a positive PCR for SARS-2 virus. And I believe everybody pretty much feels that that initial pneumonia illness and the other features that may come along with that in the early days is mediated really directly by that virus. But many of the adults develop around day 14, 12, 14 days into their illness. Even when they're improving from the first phase of their illness, they develop this and this doesn't apply to everybody, but many of them develop a hyperinflammatory condition considered a cytokine storm that in some ways resembles what we've just been talking about with the MIS-C syndrome in children, who I already emphasized don't develop that early phase like the adults do, but they can develop a hyperinflammatory situation later on, almost with similar timing with the adults. And in those adults, IVIG has been utilized, steroids have been utilized, anti-IL-6 blockers have been utilized, and with relatively good success in most patients. Some patients the cytokine storm is truly refractory, however. In those adults, myocardial disease, particularly in this hyperinflammatory cytokine storm period, myocardial disease is very common. And that's another analogy to what we're seeing in our kids.
So there are a number of questions that have to do with the use of convalescent sera to potentially treat MIS-C. Both Dr. Shulman and Dr. Krylov can answer this question.
Well, we can try. So again, I think it's much too preliminary, and it would be sort of a question in my mind of a difference between IVIG and convalescent sera. It's unlikely so far that IVIG lots, given the time to preparation, have large amounts of specific antibody for the SARS-2 virus. So again, to Dr. Shulman's point, this is a post-infectious inflammatory system. There are ways that IVIG can work to coat vessels and decrease inflammation, as opposed to if you're also looking for more specific antiviral activity, you would think that the convalescent serum would have a greater role. I don't think there's any significant experience to be able to comment on it beyond that, although to go back similarly with that concept to Dr. Shulman's last comments, this biphasic component, I think, is going to be one of the challenges in adult COVID disease, and maybe here is teasing out what is infection, what's post-infectious inflammatory, or coagulopathy as well, because early on, then you would think antivirals work, and maybe under the EUA we'll get a flavor for where remdesivir or other antivirals are appropriate. I would doubt for something like this that would be the significant role. It's more modifying or trying to modify this inflammatory response, whether it's IVIG or steroids or specific anakinra or other inhibitors to tease out. So I think I'm not sure that I can say there is a role for convalescent serum in this type of illness. It's possible, but I don't know the addition of specific antibodies are as important as in more acute disease.
Right, I would essentially agree with this, like Lenny just indicated. I think that if there is a role, or if there would be a benefit to convalescent serum, I would think it would be early on. I know that there are trials underway, and I think we'll get the answer to that because there are a number of centers that are identifying recovered COVID patients and are obtaining large amounts of plasma. Well, not too large amounts of plasma, but obtaining plasma. And those kind of trials have begun. So maybe in a couple months, if we're lucky, we'll have some information about that.
So to build on that question, this person asked, well, Dr. Schulman mentioned that this is a post-infectious syndrome. The question is, does this mean that none of the patients presented with typical COVID-19 symptoms initially, or did some of them develop typical symptoms and then later on go on to develop MIS-C?
I'll take that. We don't like to present anecdotes, but with this disease, we're so early in this disease that anecdotes might mean something. There's two things I would say. One is that I recently became aware of a paper describing two children who developed MIS-C, and in both circumstances, and these children are in different families. In both circumstances, both fathers have been diagnosed with COVID infection 4 weeks earlier, and one of the fathers had been hospitalized, the other one had not been. The children were not involved, affected in any way until 4 to 5 weeks later. They developed MIS-C. So that's one piece of evidence to support this concept. Now, here's a real anecdote. One of my colleagues in Chicago at another medical school described an 18-year-old young man who developed typical COVID adult type with pneumonia, improved, went home from the hospital, and about 4 to 5 weeks after he had the onset of his original onset of symptoms, he had the onset of symptoms that really resembled MIS-C. So there's essentially almost an adult individual who is trying to tell us that there may be a link between what we see in kids and what we're seeing in the adults. So with those anecdotes, hopefully we'll learn more about this relationship as time goes on with more than just single case anecdotes.
So
there's a question. Oh, go ahead.
No, I was just going to say I can add to the anecdotes. Our experience has been the same, that the children have presented roughly 4 weeks after an adult family member had typical COVID. And remember, other than this type of syndrome, especially the younger children, the respiratory component of COVID-19 isn't prominent. So one had maybe some mild respiratory symptoms, maybe not. So I think you may not see that initial first phase because it's not as symptomatic as described in adults. So I perfectly agree with Dr. Schulman's time course description.
So there's a question here regarding if these children are treated like they have Kawasaki, are you concerned about Reye's syndrome in children that actually have SARS-CoV-2?
So I think it's been 30 plus years since there's been a case of Reye's syndrome related to infection in Nassau County, at least where I am. So and I certainly don't know of any description, although there's some liver involvement, nothing of that magnitude with COVID-19. But one of the things, and I was actually going to bring it up, that it leads into is Reye's syndrome association with varicella or influenza plus aspirin as a precipitant. Notice the word aspirin hasn't been said till now, and I think it emphasizes the difference, maybe, as Dr. Schulman put it forth, between classical Kawasaki's and the manifestations here. And we have not certainly started with aspirin, especially in face of other features of coagulopathy and thrombocytopenia. So we haven't put that risk for out there. As they've come back to normal, till we get further data that hopefully supports that there is no coronary or other thrombotic sequelae, I'd even be less inclined to use it. We have put some, as they've gotten into higher normal, on low-dose aspirin, which again, I don't know, is the same risk as higher dose aspirin plus the infection. So putting that all together, I think it's a really, really low theoretical risk, but I also think it does beg the question, what is the role of aspirin in this post-inflammatory syndrome compared to Kawasaki disease?
Yeah, I do think that Low-dose aspirin has been used in some of the series that have been very recently published of the MISC. And with the D-dimer elevations and the fact that adult COVID patients have a coagulopathy, sometimes with serious complications. I don't know if that relates to the next thing I'm going to say, which is that I was surprised at this French series. They mentioned that 25 of the 35 patients were heparinized or given, at least given Lominox or low molecular weight heparin. They don't comment on why they did that, but it may be a carryover from the experience with adults who sometimes need anticoagulation because of their coagulopathy in the hyperinflammatory period.
So there are a number of questions regarding, are there any predisposing factors in children who are developing MISC syndrome?
I think, again, it's too early to say in a way, but I think potentially the racial or ethnic component that Dr. Schulman showed in the cases, in the case series to date, potential risks in the different African compared to the Asian populations for Kawasaki might be one, and then the age, and again, a different age distribution than classic Kawasaki's, but younger than the classic COVID seen in older adults as well. So I think those are the only two things we can say really at present.
There's a hint, if I might stick my nose in, there's a hint that maybe obesity. So in this French paper, I think it was 17% of the children were considered to be obese. In the first paper from the UK, the 8 children, six of whom were the Afro-Caribbean, I believe 5 or 6 of those children were considered obese. But the other classic comorbidities that we talk about with adults, diabetes and hypertension and heart disease and lung disease, asthma, haven't really shown up in the pediatric series of this new syndrome.
I will add that those adult risk factors, we've had some adolescents 17 to 20 who've had more typical adult COVID, if you will, and that's where we've seen those risk factors of diabetes and obesity and asthma as the risk factors. But I agree, not in this syndrome.
Okay, there are some questions regarding whether or not a patient who is presenting with potential MISC should be isolated upon admission, and should you look for co-infections in these patients? So
there's a pragmatic answer and maybe a scientific answer that are different about isolation, given that the most available testing, the PCR testing, which is mentioned, is positive in more than half of these children, doesn't differentiate between actively replicating or just presence of remnant of virus. And since even though we think it's post and we think it may not be during the acute infection, we still feel that, especially if you find it, we have to treat them as potentially infectious, certainly in a hospital setting from a infection control and safety perspective, but they may not be absolutely correct, but understand the caution that one's taking in these times.
Yes, I agree. And with a cautious approach, it may be unnecessary, but we certainly don't want to take the risk of exposing healthcare workers and anybody else to the possibility that there's still virus around, viable virus.
There are some questions regarding whether or not there are neurological symptoms that have been seen with MISC.
Yes, there are some descriptions, but again, I don't think, and some stroke-like manifestations with or without MISC and things that have been described, but in terms of a consistent pattern or frequency, I don't think we can comment yet. And I think it's too anecdotal to have an answer for that.
I
Remember,
agree
these
with
are very sick patients, potentially in shock, which can have neurologic sequelae in and of itself.
There's some iatrogenic issues. The only patient in the UK experience that died of a hemorrhage, cerebral hemorrhage complication of ECMO.
Right.
Can someone speculate on what the cause of the severe abdominal symptoms are in patients with MIS-C?
Well, I know that there are at least a couple patients described who have had laparotomies, as I said, for taking out a normal appendix, and where mesenteric adenopathy seemed to be present. And I know there's some patients who have had scans, abdominal scans. They suggested that they had an ileocolitis with thickened bowel wall. And there are some rare studies of doing PCR on fecal PCR, looking for SARS-2, and it has been positive. So they probably do have an enteritis and perhaps a lymphadenitis in response. But I think we're still learning about that.
I would agree completely.
So there are a number of questions regarding the typical time frame between the presumed acquisition of COVID-19 and the onset of MIS-C.
And I think, again, we're still learning, but I think 3-4 weeks seems to be the typical. The definition includes up to 6 weeks after presumed or likely or known exposure. Could it be more acute and more acute and rapid? I guess it's possible, but I think the 3-4 weeks is the best time frame.
Agreed.
Okay, there is actually a couple of questions regarding whether children who've had Kawasaki disease in the past are more predisposed if they get COVID-19 to develop MIS-C.
Okay, Stan, that's yours.
There's no such report anywhere yet. But, children with Kawasaki disease make up maybe 1% of the general childhood population. No, that's not. Less than that. One out of 500 or so. But so I think we're going to have a lot of more experience before we can rule that out. But so far, there's been no reports of children who had really any underlying heart disease or Kawasaki disease who then developed the new syndrome.
Okay. I think we've run out of time. I want to thank our two presenters for an excellent discussion, and I want to thank everybody for joining this webinar. We will try to make some of the information available and make the slides available, and this webinar has been recorded, so we can make this available for those individuals who either joined late and were not able to hear the entire discussion. So thank you very much and have a good evening.
Thanks, everybody.
Thanks, everybody.